Liver function test. The human liver contains a complex parenchymal cells that performs multiple functions which are essential for life. The liver is one of the large organs in the human body, weighing 1.2 to 1.5 kilograms in the adult. The liver consists of two unequal lobes. The excretory apparatus of the liver consists of a common hepatic duct, the gallbladder, the cystic duct, and a common bile duct. The liver function test represents the wide range of normal function performed by the liver. The diagnosis of the liver disease depends upon the complete history, physical examination, and evaluation of a liver function test and further invasive and non-invasive test. Many patients becomes confused regarding the meaning of a liver function test. The hepatobiliary tree represents the hepatic cells and biliary tract cells. The information of the hepatic cell results in the elevation in alanine aminotransferase, aspartate aminotransferase, and possibly the bilirubin. The inflammation of biliary tract cells result predominantly in the elevation of alkaline phosphatase. If in liver disease there are crossover between the purely biliary disease and hepatocellular disease. To interpret this, the physician will look at the entire picture of hepatocellular disease and biliary tract disease to determine which is primary abnormal function of liver. The liver plays a major role in storing blood, detoxification of blood. Parenchymal cell of the liver are related to breakdown of hemoglobin to bilirubin and remove the pigments, bacteria, and other foreign materials by phagocytosis. The parenchymal cells have a major role in maintaining the hemostasis. They play a central role in the metabolism of carbohydrate, proteins, proteins. Proteins, lipids, hormones, vitamins, bilirubin, and bile acids. The storage of vitamin, fats, cholesterol, and bile, metabolizing medications and nutrients. Limitation of liver function. This liver does not easily demonstrate dysfunctioning, at least in its metabolic activities. This is because the enormous reserve capacity and marvelous regenerating power of the liver. Only a small portion of the liver is enough to perform all the functions. About 75 to 80 percentage of liver needs to be out of functions for any type of any test to be positive. The function performed by the liver are numerous and varied. A large number of these functions are shared by other organs also. There is no single test for measuring the liver function. The whole liver is not equally or simultaneously distributed in hepatic disorder. Indication of liver function test. The results of liver function test helped in differential diagnosis of jaundice, detection of liver disease, assessment of severity and prognosis of liver disease, monitoring the treatment. Most of the liver function tests are performed on blood and urine. Basic process in disease, liver cell damage. This may vary from areas of local damage to destruction of most of the liver cells, leading to liver failure. The main causes are acute hepatitis, may be mainly viral. Chronic hepatitis is due to the continuing action of infective or toxic agents or that associated with the autoimmune response. Cirrhosis, destruction of hepatic cell. Biliary tract involvement. The involvement of biliary tract is associated with the obstruction to bile flow and may manifest as obstructive jaundice. There are two types of obstruction. The intrahepatic cholestasis mainly arises with the liver cell dissection. The main causes are viral hepatitis, used of steroids, extrahepatic cholestasis. The gallstone is a common bile duct carcinoma of the pancreas, cirrhosis of the bile duct. The LFTs are considered in the following categories. The test indicating liver cell damage, aspartate transaminase, alanine transaminase. The test indicating biliary tract involvement, alkaline phosphatase, gamma glutamyl transferase, and 5' nucleotidase. The test indicating impaired functions, serum proteins, bilirubin. Test including etiology. Test related to protein metabolism. Liver plays a central role in protein metabolism. The extensive liver damage leads to the reduction of blood flow of these proteins. The level of the serum immunoglobulins produced by the plasma cell varies widely in liver diseases, and variation in this level is a reflection of inflammation or immune response and the role of hepatocyte dysfunctioning. The important test relates to the protein metabolism or serum total protein, albumin, and globulin. Total protein, albumin, and globulin. Albumin is a major protein present within the blood. Albumin and globulin, except gamma globulin, is formed in the liver. As such, albumin represents a major synthesis protein, and it is a marker for the ability of the liver to synthesize protein. It is only one problem, only one of many proteins that are synthesized by the liver. However, since it is easy to measure, it represents a reliable and inexpensive laboratory test for physician to assess the degree of liver damage present in any particular patient. When the liver has been chronically damaged, the albumin may be low. This would be indicates that the synthesis function of liver has been markedly diminished. Such findings suggest the diagnostic of cirrhosis. Malnutrition can also be caused low albumin with no association with the liver disease. Since albumin is catabolized slowly, even in complete cessation of albumin synthesis, the serum level falls by about only 25% in 8 days. Hence, in acute liver diseases, the albumin value may be normal. The serum protein are estimated by differential precipitation of albumin and globulin fractions, and also by Biorot's method and by dye binding method. The normal value of total protein is 6 to 8 grams per deciliter, albumin 3.5 to 5 grams per deciliter, globulin 2.5 to 3 grams per deciliter, gamma globulin 0.5 to 1.5 grams per deciliter. By using electrophoresis gel, a major protein can be separated. This results in 4 major type of protein. They are albumin, alpha globulin, beta globulin, and gamma globulin. This test is useful for evaluation of patients who have abnormal liver function test, since it allows a direct quantitation of multiple serum protein. If gamma globulin fraction is elevated, autoimmune hepatitis may be present. In viral hepatitis, alpha 1 globulin is decreased and beta 1 globulin is increased. In cirrhosis and inflammation, gamma globulin is elevated. The average content of 5 main component of the serum protein is percentage. Alpha globulin 66%, alpha 1 globulin 3%, alpha 2 globulin 7%, beta globulin 9%, gamma globulin 12 to 15%. Prothrombin time. The another measure of hepatic synthesis function is production of prothrombin time. The liver synthesis clotting factors like prothrombin, fibrinogen factor 5, factor 7, and factor 10. The prothrombin is affected by the protein synthesis by the liver. Particularly, these proteins are associated with the incorporation of vitamin K metabolized into the clotting factor. This allows a normal coagulation. Thus, in patients who have prolonged prothrombin time, liver diseases may be present. Since the prolonged prothrombin time is not a specific test for liver disease, a confirmation by another abnormal liver test is essential. This may include reviewing other liver function tests or radiology studies of the liver disease, such as malnutrition, in which a decreased vitamin K is ingested in ingestion is present, may result in prolonged proton time. An increased indirect test for hepatic synthesis functioning include administration of vitamin K subcutaneously over 3 days. Several days later, the prothrombin time may be measured. If the prothrombin time becomes normal, then hepatic synthetic function is intact. This test does not indicate that there is no liver disease, but suggests that the malnutrition may coexist with liver disease. Zinc sulfate turbidity test serum is mixed with the buffer zinc sulfate solution, and the resulting turbidity is read at 680 nanometer. Hippurate acid synthesis test. The liver removes benzoic acid by conjugating it with glycine to form a hippuric acid, which is excreted in the urine. This test depends on the ability of the liver to produce a sufficient amount of glycine and to conjugate it with benzoic acid. To carry out this test, the renal function should be normal. Bromosulfathalin excretion test. Bromosulfathalin is a dye which is given up by the taken up by the liver, conjugated and excreted in the bile. The bromsulfathalin shares several steps with the bilirubin. In this process, such bindings of albumin, hepatic uptake, and intracellular transport, conjugation, and active secretion into the bile and enterohepatic circulation. Test relative to bile pigment metabolism. Bilirubin metabolism is altered when there is a increased load of bilirubin in the liver, reduce hepatic uptake, reduce intracellular transport, reduce conjugations and excretion of bilirubin, the obstruction of a flow of bile. One or more of the above problems leads to the elevation bilirubin causes jaundice. Jaundice comes from the French word jaune, means yellow. Normal serum bilirubin concentration is around 1.2 milligram per deciliter. When the bilirubin level exceeds more than 2 milligram percentage, it diffuses into the tissue, then the skin and the color of the eye turns yellow. This condition is called as jaundice. The yellowish coloration is caused by an excess amount of bilirubin in the skin. Bilirubin is yellowish and red pigment. Normally, small amount of bilirubin are found in every one blood. When too much bilirubin is made, the excess is dumped into the blood circulation and deposited in the tissue for temporary storage. Jaundice in the infant appears first in the face and upper body and progresses downwards towards the formation of formation and metabolism of bilirubin. Once bilirubin is formed, it is bind to the albumin and it is transferred to the liver. In the liver, it is secreted from the albumin and bilirubin is taken up by the liver cells. In the liver, the UDP, the glucuronyl transferase enzyme, conjugates with the bilirubin with two molecules of UDP glucuronic acid to form a conjugate bilirubin called bilirubin diglucuronide. Normally, the bilirubin is secreted into the bile through the bile duct. The conjugated bilirubin reacts with the intestine through the bile. The intestinal bacteria acts on it and deconjugate the conjugated bacteria. The free bilirubin then gets reduced to colorless tetrapyrrole urobilinogen. Then 20% of this urobilinogen is reabsorbed from the intestine and returns to the liver by portal blood. The urobilinogen is again re-excreted. The urobilinogen is also excreted through the blood, but it is negligible. The urobilinogen is further reduced to streptobilinogen and excreted to the feces. The urobilinogen and streptobilinogen are colorless compounds, but when they are exposed to atmospheric oxidation, they are converted to color urobilin and streptobilin respectively. The conjugated water-soluble bilirubin, when treated with a diazo reagent, gives a red color immediately. This is called direct Van de Berg test. The conjugated bilirubin reacts directly without adding methanol, so it is called as a direct bilirubin. The water insoluble unconjugated bilirubin gives a positive Van de Berg test only if methanol is added to the serum. This is direct Van den Berg test. This is also called indirect bilirubin. The water soluble free conjugate bilirubin can be filtered through the glomerular membrane and excess of urine and excreted in the urine when there is increase in blood level of conjugated bilirubin. The water insoluble unconjugated bilirubin is not filtered by the glomerular membrane and it is bound to the albumin. Hence, it does not appear in the urine whenever the blood level of unconjugated bilirubin is increased. There are three different types of jaundice. Hemolytic jaundice. This type of jaundice mainly arises due to the excessive breakdown of red blood cells. This type of jaundice is commonly in a newborn when where bilirubin formed and releases into the bloodstream when RBC are broken down. The infants have too many RBCs in a natural process. The baby's body to break down excess red blood cells, forming a large number of bilirubin. It is this bilirubin that causes the skin to take on the yellowish color. The newborn liver is immature and cannot process bilirubin as quickly as it will be able to when in this get older. This slow processing of bilirubin has nothing to do with the liver disease. It is merely meaning that the baby's liver is not fully developed and it will be and thus there is some delay in elimination of bilirubin. Most babies with jaundice have a psychological jaundice. Occasionally there is other factors that causes jaundice. In fact, two of these are conditions they are known as ABO incompatibility and RH incompatibility. Both of these conditions result in the very fast breakdown of RBC. Also, jaundice can be appeared in the infants and physical defects in the organs that works to eliminate bilirubin from the body and decreases conjugating enzymes. Treatment of neonatal jaundice. If the level of bilirubin is high and needling treatment, it is usually treated with phototherapy. This means the undressed baby is placed under the special light. The light may be white, blue, or green. or the baby may be placed in a light protecting blankets. The light helps to break down the bilirubin in the stain and the skin. It may cause the baby to have a running stool. It may not be good for babies to have bright light continuously shining in their eyes. The eyes are covered to protect them from such a light. If the baby has only a photo therapy blanket, the eyes do not need to be covered. Biochemical findings: elevated total bilirubin. Hepatic jaundice. This type of jaundice mainly arises due to the damage of parenchymal liver cells. The biochemical findings: high total bilirubin, yeah, alkaline phosphatase increases moderately, and very high AST and ALT. Alanine transferase. The obstruction or prosthetic jaundice. Obstruction to the flow of bile causes the conjugation bilirubin to return to the blood. Therefore, the serum contains an increased amount of bilirubin, diet bilirubin. Biochemical findings: high total bilirubin, high direct bilirubin height, marked increase in the serum of alkaline phosphatase and direct bilirubin, moderate increase in AST and ALT. Thus, alkaline phosphatase and bilirubin estimation can be used as one of the indicates of differential hepatitis jaundice and prosthetic jaundice. Serum bilirubin estimation by Malley and Evelyn's method. Urobilinogen urine and feces. The presence of urobilinogen in the test sample can be demonstrated by the test based on the production of red color when urobilinogen reacts with the RH aldehyde reagent. The excess bilirubin formed in the hemolytic jaundice enters the intestine through the bile. There it will be converted to urobilinogen. Then it leads to the excretion of more urobilinogen in the urine and feces. In a patient with liver disease accompanied by hepatic cellular damages, the relative cells bilirubin is excreted in the intestine through the bile as compared to the normal person. However, during the erythrohepatic circulation, the excretion of urobilinogen by the hepatocyte is impaired, resulting in the release of higher portion of urobilinogen, which is subsequently appears in the urine. Therefore, the amount of urobilinogen in the urine is higher than normal in this condition, but in feces it is very low. In patients with obstructive jaundice, the urobilinogen in the urine and feces is reduced or absent. The stool is the obstructive jaundice. Is clear for several reasons. The urine and feces urobilinogen determination do not provide useful information for the evaluation of hepatobiliary disease. Serum enzyme in liver disease. The assay of serum enzyme is very useful for the differential diagnosis and monitoring of various hepatobiliary disorders. There are three types of enzymes. Enzymes which are normally present inside the hepatocyte released into the blood when there is hepatocellular damage. The markers for hepatocellular disease. Enzymes which are primarily membrane bound markers for cholestasis. Enzymes which are synthesis in the hepatocyte indicates disturbance in the cellular synthesis. Evidence of hepatocellular damages. Serum transaminase. The aminotransferase catalyzes the chemical reactions in which an amino group from the one amino acid is transferred from the donor molecules to a recipient molecule. Hence, the name aminotransferase. Another name of aminotransferase is transaminase. The enzyme aspartate aminotransferase is also known as a serum glutamic oxaloacetic transaminase. The alanine aminotransferase is also known as a serum glutamic pyruvic acid transaminase, SGPT. The aspartate transform AST and alanine transfer ALT. The location of AST present in the cytosol and mitochondria. The ALT the location in the cytosol of the liver. In the liver, the concentration of ALT per unit weight of a tissue is more than the AST. These enzymes are more important in assessing and monitoring the degree of liver cell inflammation and necrosis. Higher activity of alanine transaminase are found in hepatocytes and muscle cells. Again, the hepatocytes has very high activity of ALT. Therefore, the elevation in scrum ALT are considered to be relatively specific for the liver disease. The aspartate transaminase may be elevated in other forms of tissue damage, such as myocardial infraction, muscle necrosis, and renal disorder. In the liver disease, the alanine transaminase level is increased markedly compared with the aspartate transaminase. In acute viral disease, there is a 100 to 1000 times increase in both ALT and AST, but alanine transaminase level is increased both more than that of aspartate transaminase. A variety of medications can cause abnormal liver enzyme level. Examples of some of the common medication with potential liver toxicity includes aspirin, acetophenone, etc. Evidence of a evidence of a cholestasis, alkaline phosphatase. The serum alkaline phosphatase elimination is the most widely used biochemical test to put in evidence for the cholestasis of intra and extra hepatic origin. The alkaline phosphatase is a monoesterase enzyme whose optimum pH is in the alkaline range. It is localized in the microvilli of biliary caniculi located in the plasma membrane. Beside liver, the alkaline phosphatase is also located in other tissue like bone, kidney, placenta, and small intestine. There are 5 isoenzymes of alkaline phosphatase corresponding to the 5 classes, 5 tissue of origin. The alkaline phosphatase from liver is the fastest moving isoenzyme seen in electrophoresis. Normal level 4 to 13 Ka unit or 40 to 140 international unit per liter. The increase in serum level of alkaline phosphatase from the liver is a very sensitive indicator of cholestasis. The elevated alkaline phosphatase in cholestasis may be due to two factors, regurgitation of ALP from bile to blood, increase synthesis from the cell lining the biliary caniculi. In obstructive jaundice, the alkaline phosphate level becomes very high. The method of estimation of King and Armstrong method. In this hepatitis gamma glutamyl transferase. This enzyme catalyzes the transfer of a gamma glutamyl group from glutamyl peptide to another peptide or amino acids. Tumor markers to hepatitis. The combination of a hepatic itis, inflammation of liver. The causes of hepatitis can be divided into infectious and non-infectious. Infectious causes includes bacteria and more commonly viruses. Any attack by foreign organisms to the liver can kill hepatocytes and recruits inflammatory cells. The inflammatory diseases are long-term chronic conditions that must be managed medically. Among inflammatory disorders, the infections are most common. For correct diagnosis, it is important to understand the host immune response, the disease and clinical stage, and type of the viral hepatitis. Hepatitis A caused by the hepatitis A virus. Of these, hepatitis A and E are spread through the contaminated food and water, whereas hepatitis B, C, D are spread parentally, sexually through transfusion of infected blood by use of infected needles. Hepatitis A virus. Hepatitis A virus is a enterovirus. Hepatitis A virus does not cause chronic hepatitis or carrier state, so fatality associated is only 0.1%. Hepatitis A antigen. Hepatitis is a small and unenveloped single standard RNA containing viruses, and it is only hepatic viruses which has been grown in culture. It is spread by the ingestion of contaminated water and food, and it is shed in the stool for 2 to 3 weeks before and 1 week after the onset of jaundice. Thus, close personal contact or fecal oral contamination during this period accounts for most cases. The prevalence of infection is measured by the presence of hepatitis A virus and antigen and hepatitis A virus antibody IgG and IgM. Hepatitis A virus IgG. It is used as a marker for past hepatitis infection. It peaks after the acute illness and remains detectable indefinitely, perhaps lifelong. The demonstration of hepatitis A virus IgG indicates the previous infection. It protects against the subsequent infection with hepatitis A viruses, but it is not protective against hepatitis B or other viruses. Hepatitis A virus ABM. The determination of IgM antibody to hepatitis A virus in serum or plasma aid in the diagnosis of acute or recent hepatitis A virus infection. Hepatitis A is a self-limiting disease and it is often a subclinical disorder, particularly in children. Since the symptomatic hepatitis A virus infections can be clinically indistinguishable from the infection with hepatitis B and C virus. The serological testing is an important tool to achieve the proper diagnosis. During the acute phase of hepatitis A virus, the IgM cell antibody to the hepatitis A virus appears in the serum and is nearly always detectable at the onset of symptoms. In most cases, IgM and anti-hepatitis A virus response usually peaks within the first 6 months, declining to the non-detectable levels within 12 months. Hepatitis A, IgM anti hepatitis HAV is not detected in normal subject whether or not they have the IgG antibody to the hepatitis A virus, hepatitis B virus. The hepatitis B virus is a hepatinovirus. It is a small annual DNA virus containing 3.2 kb. The hepatitis B virus consists of a surface and a core. The core containing DNA polymerase and E antigen. The DNA structure is double-stranded and circular. There are 4 major polypeptide reading frames. The S gene codes for the protein surface antigen and envelope glycoprotein present on the outer surface. The core gene is divided into 2 regions, the pre-core and the core, and the codon for different proteins. The core antigen, hepatitis B antigen, and the E antigen. The P polymerase and the X transcriptional transactivation active. Hepatitis B virus is classically acquired through the blood transfusion. It is present in blood and all physiological and pathological body fluid. Thus, blood and blood fluids are the primary vehicle of transmission. The virus may also be spread by contact with the body secretions such as saliva, sweat, semen, tears, breast milk, and pathologic effusion. Hepatitis antigen. It indicates the patient is infected with hepatitis B virus. It is the first serological marker to appear post-infections, especially important for pre-transfusion diagnosis. The persistence for more than 6 months indicates a chronic state. Core IgM antibody of hepatitis B virus core antigen. The determination of IgM antibody to hepatitis B virus core antigen in human serum or plasma aids the diagnosis of acute and recent infections. It is a reliable marker for the acute viral diseases. Anti-hepatitis B core is detected in before or after onset of the symptoms. However, such reactivity can persist for years after the illness, may even outlast anti-hepatitis B and occasionally may be the only marker of either current or past infection. Several studies have been demonstrated that IgM anti-hepatitis B is the only specific marker for the diagnosis of acute infection with hepatitis B. Hepatitis B envelope virus. Hepatitis B envelope antigen the determination can be used to monitor the progress of hepatitis B virus infection. Hepatitis B envelope antigen is found in early phase of hepatitis B infection after the appearance of hepatitis B surface antigen. The titer of both antigen rises rapidly during the period of viral replication. The presence of hepatitis B envelope antigen correlates with the increased number of infectious viruses, the occurrence of core particles in the nucleus of hepatocyte, and presence of viral specific DNA polymerase in the serum. During the hepatitis B envelope antigen positive stage, hepatitis B patients are at risk of transmitting the viruses to their contact. The persistence of hepatitis B envelope antigen in the hepatitis B virus carriers is often associated with a chronic active hepatitis. Hepatitis B envelope. The detection of antibody to hepatitis B envelope antigen in human sera or plasma aids the diagnosis of monitoring hepatitis B viral infections. Hepatitis B envelope antigen and its antibody, the hepatitis B envelope, are found only in the association with hepatitis B viral infections. Hepatitis B envelope antigen becomes undetectable after the peak of viral replication and onset of resolution of disease. The negative hepatitis B envelope antigen results alone may indicate early hepatitis B envelope antigen leukemia before the peak of viral infections or early convalescence when hepatitis B envelope antigen has declined below the detectable levels. The presence of anti-hepatitis B envelope serves to distinguish between these two periods. The appearance of hepatitis B hepatitis B envelope indicates the reduced level of infection virus due to the decrease in the viral replication. Hepatitis C virus. Hepatitis C virus is an envelope blood-borne virus closely associated with the blood transfusion. Serologic study employing the enzyme immunoassays for detection of antibodies to recombinant antigen of hepatitis C have been established. Hepatitis C as a cause of most blood-borne as well as community-acquired non-A and non-B hepatitis. The presence of anti-hepatitis C virus indicates that an individual may have been infected with hepatitis C, may harbor infection hepatitis C and or may be capable of transmitting hepatitis C infection. Although the majority of the infected individuals may be asymptomatic, hepatitis C virus infection may develop into chronic hepatitis cirrhosis or increase risk of hepatocellular carcinoma. The implementation of blood screening from the anti-hepatitis C virus before the blood transfusion decreases the risk of transfusion transmitted hepatitis D. Hepatitis D. The hepatitis D virus is a small circular RNA virus. The hepatitis D virus is replicated defective and therefore cannot propagate in the absence of small viruses. In humans, hepatitis D virus infection only occurs in the patient with hepatitis B infections. Hepatitis E virus is an important cause of enterically transmitted acute viral hepatitis in several development countries, and it is transmitted by the fecal overload. In the disease endemic areas, the individuals who have recovered from the acute hepatitis E are unlikely to serve as a reservoir of hepatitis E virus.